Hi, my name is Katerina Zaka. I'm an internal medicine resident at Wellstar Atlanta Medical Center. Today, I'm going to be presenting a research study entitled Pulse Temperature Deficit in Hospitalized COVID-19 Patients. I'm going to be presenting on behalf of Chelsea Keeney, Luis Nieto, Sina Attar, Aviat Lima, Renjan Jang, Brian Perlman, and Miriam Parker. As an introduction, pulse rate usually increases by about 10 beats per minute for each 1 degree Fahrenheit increase in body temperature. This is known as Liebermeister's rule. However, pulse rate does not always increase as expected, creating a relative bradycardia known as pulse temperature dissociation, which is also called Fagin sign. Pulse temperature dissociation is well described in certain infections such as yellow fever, tularemia, and Salmonella typhi infections. The association between fever and pulse rate has not yet been thoroughly investigated in patients with COVID-19, so the aim of this study is to investigate pulse temperature dissociation as a characteristic clinical feature in patients with fever due to COVID-19 infection. Our study is a population-based retrospective study using a multi-institutional database. We correlated the timing of the pulse relative to the time when the Tmax was recorded, measured concurrently. The definition of pulse temperature deficit was an increase in pulse rate less than 10 beats per minute for each 1 degree Fahrenheit rise in body temperature above normal. These are various methods in which you can calculate whether someone has a pulse temperature deficit. In our study, we utilize method 3, which is called the unitary method. It's basically that you add 10 for each 1 degree Fahrenheit above 102 to 110. For example, if the patient had a temperature of 103, you would add 110 plus 10, which is equal to 120. So the expected pulse would be 120, and anything less would be considered a pulse temperature deficit. Statistical analysis of the study, basically eligible patients' demographic and disease information were described with the appropriate descriptive statistics. Numerical variables were presented with median, standard deviation, median, and range, and categorical variables were presented with frequency and percentage. And we performed statistical analysis by using the SAS 9.4 software. Our inclusion criteria were adults age greater than or equal to 18 years, COVID-19 confirmed either through rapid Abbott ID Now or diathrics test, febrile patients greater than 100.4 with a Tmax recorded during hospitalization, and diagnosis between February and September of 2020. Exclusion criteria included patients who had any known factors that could affect pulse rate, such as concurrent conditions with cardiac conduction disease or medications with negative chronotropic effects, such as beta blocker, digoxin, non-dihydropyridine, calcium channel blockers. So a total of 150 patients were included in the final analysis. The gender distribution, the majority were actually female, accounting for 53%. And in terms of the racial distribution, the majority were non-Hispanic white, accounting for 47%, compared to African American at 27%, Hispanic at 21%, and then other at 5%. The median age was 45 years with a range of 18 to 97 years. So the following table depicts the patient characteristics of this study. So in terms of the Charlson Comorbidity Index score, those with a score of 0 accounted for about 46%, score of 1 accounted for about 26%, and score of 2+ accounted for about 28%. In terms of insurance status, mostly patients had private insurance at about 48%, and then government insurance at 30%, none at 22%. And then the majority of patients as well had a pulse temperature deficit with around 51% of the population having a pulse temperature deficit. Hospital length of stay, the median was about 2 days with a range being from 0 to 39 days. Patients with a pulse temperature deficit also had a similar distribution amongst age at diagnosis, CCI score, race, gender, insurance, and hospital length of stay compared to patients with no pulse temperature deficit. Mean hospital length of stay among patients with a pulse temperature deficit was 4.26 compared to 4.29 in patients without a pulse temperature deficit, with a p-value of 0.978. So this is the univariate association with bradycardia. So as you can see, patients with the pulse temperature deficit compared to those without the pulse temperature deficit really had a similar distribution in patient characteristics amongst all the covariates, with p-values not reaching any significance in any of the covariates. So the limitations, confounding factors such as volume depletion and anemia were not accounted for in this study, which could affect pulse. And the fact that the small sample size in this study was also considered a limitation. So the conclusions we drew: characteristic signs and symptoms associated with clinical disease are well regarded for their historical import and carry a particular interest for clinicians on the front lines. Although not significantly associated with any demographic or disease characteristic analyzed, a pulse temperature deficit was found in more than 50% of hospitalized patients with COVID-19 related fever. This sign appears to be a clinical clue which may prove helpful in the diagnosis of COVID-19 if confirmed in larger and more heterogeneous populations. These are the references we utilized for this study. Thank you. Any questions?